This was a lovely study presented by Thanos Dimopoulos as an oral presentation at EHA, as you so nicely framed. And what struck me about Thanos' data was really several things. First and foremost, it's a further validation of the importance of maintenance, be it with an immunomodulatory agent, which is currently the standard of care. Now, obviously, with Ixazomib showing that it can confer clinical benefit in this setting. And I think as we think of the way forward, there are a subset of patients in whom lenalidomide maintenance is problematic. And as a result of that, this is an important addition to the armamentarium. In other words, one could offer them a proteasome inhibitor-based maintenance strategy that does not require infusional therapy and can be given orally, which is tremendously important as we think about the implications of COVID. But I think beyond that, I personally consider lenalidomide a standard of care, and I use it until progression. I always like to add a proteasome inhibitor to it, particularly in the setting of when I don't use autologous transplant and when I have a patient with high-risk features. And I think the important point about MM4 is that at a very highest level, phase 3 in multi-center international study, we see clear evidence of clinical benefit. And I think a couple of things about the study, just for the purposes of the discussion today: 706 patients enrolled, and about a third of them, in fact, actually probably about 40% of them, in fact, were 75 or older. So this is very important. So it's a non-transplant population. They received a variety of induction regimens, and if they achieved a PR or better after successful induction, they were then randomly assigned on a 3-to-2 randomization. And this study was placebo-controlled, which means it's really the highest quality of evidence. And if you look at the induction remission regimens, Charlie, the majority, in fact, were not IMiD-based, actually. They were VMP and Cyborg-D. So clearly this is probably more relevant in terms of the induction strategy to a non-US practice, but certainly important in European and ex-US practice. But putting that to one side, what was particularly striking is the intent to treat population. The PFS gain was substantial, essentially a doubling of PFS. And what you saw was a median PFS of around 9 months for the control group. And then if you looked at the patients who received Ixazomib maintenance, that was effectively doubled and was actually around 17.5 months. The hazard ratio was impressive. It was around 0.65 or so. And very importantly, the p-value was highly statistically significant. Now, the data are immature from the point of view of survival, so I think that that's obviously something that's cooking. But what was also impressive to me, at least, was that the tolerability profile was very reassuring. I always look to study drug discontinuation rates to give you a real clue as to how things are doing, and those were modest, very modest, around 13% for the Ixazomib arm and just 9% for the placebo. So the difference, obviously, is very marginal. And if you looked at the side effect profile for the Ixazomib patients, we saw nausea, vomiting, and diarrhea, but at a very low level, grade 1, 2, and again, at any significance level, really small numbers. So again, a well-tolerated platform. The rates of second primaries, very low, identical in both arms, 5% and 6% respectively. So I think this then provides us with a nice platform going forward. What we can see is that Ixazomib in the non-transplant population has a role. We already know from a previous study that, again, Thanos led, looking at Ixazomib maintenance versus placebo in the transplanted population, there was a median PFS gain, again, around about 6 months. And again, clinically important, certainly from my perspective. So I think we've seen the establishment now of Ixazomib in a maintenance setting, recognizing that in US practice, and certainly in my practice, partnering Ixazomib with an IMiD would be my preferred approach. And at the same time, in high-risk patients, I think this is particularly important. Now, obviously, right now, many of us use bortezomib as a maintenance strategy, typically every 2 weeks. This data, I think, reinforces the rationale that if something other than bortezomib is considered, and an all-oral approach obviously has tremendous advantages for all sorts of reasons, this is, in my opinion, now a very viable option.